Today, we are going inside. Deep inside the gut.
Right into the stomach.
Exactly. We're going to investigate that relentless chemical conflict that really shapes so much of modern life.
The war between acid and our own defenses.
It's a phenomenal area of human physiology, isn't it? Something you really only notice when that delicate balance fails.
That's right. And that's when we start talking about peptic ulcer disease, PD, and gastroesophageal reflux disease, or, GERD. These conditions are, at their core, a breakdown in the biological armor that protects our digestive tract from its own really potent machinery.
So we've synthesized a massive stack of sources for this one, heavily weighted towards some very detailed pharmacology and physiology texts. They really map out this internal battlefield. We're looking at the targets, the mechanisms of injury, and, most importantly, the specific molecular weapons, the drugs.
And our mission today is to give you a genuine shortcut to expertise on this. We want to move way beyond just, swallow a purple pill for reflux. We want to understand the precise evolution of these treatments.
Right. Why the old H2 blockers were so revolutionary, but also kind of flawed.
Exactly. And what makes the modern proton pump inhibitors, the PPIs, so devastatingly effective.
And, crucially, what long-term compromises we're making when we exert this level of pharmacological control over a fundamental bodily process.
It's a fascinating story of chemical cat and mouse.
Okay, let's unpack this. Let's start with the architecture of the problem. We're calling this the acid factory.
Right. So to treat acid-related diseases, we first have to really define them. PE is essentially an erosion. Think of it like a hole or a sore in the lining of the stomach or the duodenum that's just constantly exposed to these aggressive factors.
And those factors are powerful acid and the protein-digesting enzyme pepsin.
A very corrosive mix. GERD is similar, but the damage happens when that mixture backs up or refluxes into the esophagus, which isn't built to handle it.
The sources all define PUD as this failure of balance. Aggression versus defense. But what are the most crucial contributors to that failure today?
Well, historically, we thought it was all about lifestyle, stress, spicy food.
Right, the classic ulcer story.
But modern medicine has really zeroed in on two dominant causal factors. First, the incredibly common Helicobacter pylori infection. It weakens the mucosal defense system and just allows the acid to attack.
And the second one?
The heavy use of nonsteroidal anti-inflammatory drugs, so NSAIDs. Think ibuprofen, naproxen, things like that.
And that distinction is fascinating, because the sources point out that the location of the ulcer often tells you which system failed.
Exactly. It's a huge clue. When we see duodenal ulcers, those in the small intestine right after the stomach acid secretion is usually high, it's an aggression problem.
Too much acid.
But with gastric ulcers, the ones right in the stomach lining, the acid secretion might actually be normal or even low.
So what's the problem there?
It's a profound failure of the defensive mechanisms, often because NSAIDs have inhibited the prostaglandins that are needed to maintain that protective mucus layer.
Okay, so whether the problem is too much aggression or not enough defense, the ultimate therapeutic goal for pretty much all these drugs is to control the output of the mechanism of acid production.
And that mechanism leads us to the superstar of this whole story, the parietal cell. These are specialized cells in the stomach lining, and they contain the terminal enzyme responsible for all acid output. This is the H plus K plus ATPase.
Which we all just call the proton pump.
The proton pump, it's the perfect name.
It really is a perfect description, isn't it? It's literally a pump that moves hydrogen ions. That's the H plus and HCl, hydrochloric acid, out of the cell and into the stomach.
And this is the critical point. It is the ultimate, final common pathway.
The single spigot in the whole system.
That's a great way to put it. Every stimulus, every hormone, every nerve message that encourages acid production has to, in the end, funnel through that one single pump. So if you can target that spigot, you control the entire operation.
So how does the cell decide when to turn that spigot on? We need to understand the regulation, and our sources point to 3 key messengers.
Right. The parietal cell is constantly listening for input through 3 different types of receptors on its surface. Each one responds to a different chemical signal. The first, and historically the most important, is histamine, which binds to the H2 receptor.
And histamine isn't just floating around randomly.
No, not at all. It's released by specialized neighboring cells, the enterochromatin-like cells, or ECL cells. And they are themselves triggered by other signals like gastrin or acetylcholine.
So it's a chain reaction.
It is. When histamine binds to that H2 receptor, it kicks off a strong signal inside the parietal cell using a second messenger system called CAN-MP.
And that powerfully activates the proton pump.
Powerfully. It's the main accelerator.
Okay, that sounds like the big one. What are the other two inputs?
The second is acetylcholine, or ACE, and that acts on M3 receptors. AP is the neural signal. It's released by the vagus nerve and the enteric nervous system.
Basically, the hey, food is coming message you get when you smell something delicious or start chewing.
Exactly that. ACE uses a different signaling pathway, though. It activates the pump via an increase in intracellular calcium ions, Ca2 plus LIC.
A different pathway, but the same result. Pump gets activated, and the third messenger is hormonal.
That's gastrin, which binds to CCK2 receptors. Gastrin is a hormone released by G cells in the lower part of the stomach. They respond to food, AC, and other peptides.
And like AC, it uses the calcium pathway too.
It does. It also activates the pump via calcium.
So we have these three distinct inputs, histamine, AC, and gastrin, and they all converge on the same final pump. But here is the critical physiological insight our sources highlight. The H2 receptor activation is absolutely necessary to get the maximal acid response.
This is the insight that launched the entire first generation of successful pharmaceuticals. It was a game changer. Histamine functions like the master amplifier in the system.
So even if AC and gastrin are firing off signals,
they need that histamine H2 pathway running at full blast to reach peak production. If you block that H2 receptor, you don't just block the histamine effect, you significantly weaken or attenuate the response to all three stimuli.
You've basically crippled the entire output system.
You have.
And that realization takes us directly into the evolution of acid suppression. We started by crippling the system with H2 blockers, but we ended up basically abolishing it with PPIs.
Let's start with that first revolutionary step. The H2 antagonists, or blockers. These were the first really targeted, powerful anti-acid drugs. And their mechanism is, well, it's simple and elegant. They are competitive antagonists at the H2 receptor.
Meaning they're structurally similar enough to histamine that they can sit in the receptor's docking bay, but they don't send an activation signal.
They're chemical roadblocks. They just sit there and prevent histamine from binding.
Got it.
And by blocking that crucial amplification step, they significantly reduce the total volume of gastric juice, the pepsin content, and even the secretion of intrinsic factor.
When these first hit the market, what was their clinical impact? I mean, they must have been huge.
Oh, they were absolute game changers. They offered targeted relief and could heal 60 to 70% of ulcers pretty quickly. They're still used today for milder GERD and for preventing stress ulcers in hospitals.
And the key comparison point is that they are generally faster acting than PPIs for immediate relief, right? You feel them working sooner.
You do. But they just lacked the raw power needed for maximal complete healing in really tough cases.
And there's that interesting nuance about timing. The sources say they suppress nocturnal acid secretion more effectively than daytime acid secretion. Why is that?
That is pure physiology. Basal acid secretion, that's the low continuous acid production that happens when you're not eating, mostly overnight, is maintained almost entirely by the continuous low-level release of histamine.
Okay, so it's a histamine-driven process at night.
Almost exclusively. Since H2 blockers target histamine directly, they are incredibly efficient at shutting down that basal resting acid output.
But daytime secretion is different.
Very different. It's driven by meals, which activates all three pathways, AT, gastrin, and histamine. So the H2 block is less effective against that total acid surge.
Let's talk a bit of history here with cimetidine. This was the prototype, the very first one, but it came with some serious chemical flaws that really pushed for a next generation. What were the trade-offs?
Cimetidine was a pharmacological miracle, but it was a clinical challenge. It had two major systemic side effects that had nothing to do with the stomach. The first was its anti-androgenic action.
Okay, what does that mean in practice?
It could compete with male hormones, like dihydrotestosterone, for receptor sites elsewhere in the body. In men taking high doses for a long time, this could lead to things like gynecomastia, impotence, and a decreased sperm count.
Wow, that's a powerful illustration of how a drug designed for one target can accidentally hit others if it isn't specific enough.
Right.
What was the second, more dangerous issue?
The second was its widespread disruption of drug metabolism through CYP-P450 inhibition.
Right, that's the liver's main drug processing system, the one that cleans everything up.
That's the one. And cimetidine inhibits several major enzymes in this system. It just gums up the whole works.
So if you were taking cimetidine alongside another drug, say a blood thinner like warfarin, or an anti-seizure medication like phenytoin, what happened?
Cimetidine would essentially shut down the liver's ability to clear that second drug. So the concentration of the warfarin or phenytoin would just build up in the bloodstream.
Leading to dangerously toxic levels.
Exactly. For drugs that have a narrow therapeutic window, this was a massive, massive risk. It required constant monitoring and dosage adjustments.
So the goal for the second generation was clear. Keep the H2 blocking power, but design out all that systemic messiness.
Precisely. And that led to ranitidine and, even better, famotidine. Ranitidine was more potent and had a longer half-life, about 2 to 3 hours, which meant less frequent dosing than cimetidine.
But famotidine seems to be the one that really delivered that true chemical refinement.
It is the champion of this class, for sure. Famotidine contains a thiazole ring, and it's 7 to 10 times more potent than ranitidine. But more importantly, it was engineered to have a very low affinity for the CYP450 enzymes.
So it basically solved the drug interaction crisis.
It did. Famotidine became the clean drug, the one that was safe to prescribe alongside complex regimens without that fear of massive metabolic disruptions.
And before we move on, our sources also mention lifutidine, which is used mainly in Asia. It seems to take a slightly different approach.
Lifutidine is a really interesting evolutionary path. It still has the H2 blocking power, but it adds direct gastroprotective effects. It actually increases mucosal blood flow, ramps up mucus production, and stimulates somatostatin release.
So it's helping the body's own defense mechanisms while also slightly reducing acid?
Yes, it shows that even within an old drug class, there are still avenues for innovation that focus on defense, not just on shutting down aggression.
That brings us to the moment where we stop just crippling the system and start completely abolishing it. The arrival of the proton pump inhibitors, PPIs. This wasn't just an improvement, it was a revolution that completely changed how we treat PU and GERD.
Absolutely. The PPIs, with omeprazole being the prototype, are the undisputed current standard. They are the most potent acid suppressants we have, period. They're capable of nearly 100% acid abolition.
And their mechanism isn't just strong, you said it's chemically genius.
It is.
Let's break down the mechanics because this is probably the key takeaway for you listening. How do they achieve this near-total permanent suppression?
It's a really elegant two-part strategy. First, they are prodrugs.
Meaning the chemical you swallow is actually inactive.
Largely inactive, yes. It only becomes active when it diffuses into the specific microenvironment of the parietal cell canaliculi, that tiny, highly acidic space right next to the proton pump, where the pH is below 5.
So they're designed to sneak through the body, only turning on the moment they reach their ultimate target. That minimizes chemical exposure everywhere else.
Precisely. And once they're activated by that acid environment, the second definitive step occurs. The PPI metabolite binds covalently and irreversibly to the H plus K plus ATPase pump.
This is the crucial difference. The H2 blocker was a temporary competitive roadblock. This is a permanent chemical lockdown.
That's the perfect analogy. You are welding the spigot shut.
Yeah.
And because that binding is irreversible, that specific pump molecule is now permanently disabled.
So acid secretion can only resume when?
When the cell manufactures brand new H plus K plus ATPase molecules and integrates them into the membrane. And that takes a full cycle, about 18 hours.
Which is why PPIs just completely abolish hydrochloric acid secretion, regardless of what the stimulus was. Histamine, gastrin, ACH. It doesn't matter.
It doesn't matter. They've shut down the final common pathway.
That explains the incredible power, but it brings up a question I think a lot of people have. If the binding lasts 18 hours or more, why do you still need to take a PPI every day? Doesn't the effect linger?
That's a great question, and it really speaks to the limitations of pharmacology. You're right, the effect on the bound pumps lasts for days. The problem is the PPI itself has a very short half-life in your bloodstream, only 1 to 2 hours.
So it's cleared out of the body quickly?
Very quickly. To maintain that maximal suppression, we need to continuously disable the new pumps that the parietal cell is constantly making and putting on its surface.
So daily dosing is about catching that fresh wave of newly synthesized pumps?
Exactly. That's how we get to that maximal sustained suppression of 80 to 98% within about 3 or 4 days.
And then there's the logistical headache of PPIs. They are extremely acid labile. They're destroyed by acid. So how do they survive the stomach to get absorbed in the first place?
They require very specialized manufacturing. They have to be packaged in an enteric-coated form, either as tablets or little granules. This coating is designed to resist the acid in the stomach and only dissolve when it reaches the more neutral pH of the duodenum,
which allows for safe absorption into the bloodstream,
from which they then diffuse back to the parietal cells to do their job.
And timing is everything. Our sources stress they must be taken before a meal, usually breakfast. Why is taking it 1 hour before food so critical?
Because the PPI only binds to pumps that are actively secreting acid. In a fasting state, only about 10% of your proton pumps are operational.
The rest are just waiting.
They're waiting. When you eat, the hormonal and neural signals mobilize the maximum number of pumps to the surface of the cell, up to 60 or 70%.
So you need the PPI concentration to be peaking in the bloodstream right when the maximum number of targets are exposed.
That's the only way it works. If you take it after a meal, the pumps have already done their work, and the drug just misses that peak action window.
The clinical superiority here is just undeniable. PPIs provide faster healing and vastly superior rates. We're talking 90% of duodenal ulcers healed at 4 weeks.
It's a different scale of acid suppression. They just blow H2 blockers out of the water, especially in tough cases.
Let's quickly distinguish between the different prazoles. We have omeprazole, but why did we then develop the others?
It was mostly about refinement, slight differences in metabolism, and, intellectual property. Esomeprazole is probably the most noteworthy. It's the S enantiomer of omeprazole.
A mirror image of the molecule.
Exactly. And that subtle chemical difference means it has a slightly higher oral bioavailability, and some studies suggest it offers better control of the intragastric pH. It just keeps that pH barrier higher more consistently.
And drugs like lansoprazole and rabeprazole.
Lansoprazole has a bit of a faster onset and a slightly shorter half-life than omeprazole, but the overall clinical efficacy is very, very similar across the whole class. Rabeprazole is claimed to convert to its active form even more rapidly, so it might speed up that initial acid suppression.
But the key message is they all deliver that same powerful, irreversible shutdown.
That's the bottom line.
We mentioned simetidine's P450 problems earlier. Do PPIs carry any similar drug interaction risks?
They do, though generally less severe than cimetidine. The most clinically important interaction involves omeprazole and the critical antiplatelet drug clopidogrel.
Okay, that sounds serious.
It is. Omeprazole inhibits the CYP2C19 enzyme, which is the exact enzyme needed to convert clopidogrel into its active clot-preventing form.
So by taking omeprazole, you could be unknowingly reducing the effectiveness of your blood thinner, which could raise your risk of a heart attack or a stroke.
Precisely. It's a very serious interaction, and it's led many physicians to prefer other PPIs, like pantoprazole, which show less inhibition of that specific enzyme. They're just a safer profile for cardiac patients.
Now we come to the critical discussion that I think defines the complexity of modern medicine: adverse effects and long-term risks. If we have this power of total acid abolition, what are the trade-offs when patients use these drugs for years and years?
This is really the shadow side of pharmacological mastery. Long-term high-dose use, and we're talking over a year, is associated with 3 major risks that can affect the entire body. Let's start with accelerated osteoporosis.
And this is a direct mechanical link to the lack of stomach acid, right?
Absolutely. The body requires an acidic environment to effectively solubilize and ionize calcium, which is necessary for it to be absorbed in the intestines.
So if you keep the stomach pH above 4 or 5 all the time,
You drastically reduce the body's ability to absorb calcium. Over many years, this leads to a negative calcium balance, it accelerates bone loss, and it increases the risk of hip, spine, and wrist fractures, especially in the elderly.
So the very acid that causes the disease is also essential for nutrient uptake. It's a classic double-edged sword.
It is.
What about the feedback loop in the stomach itself, hypergastronemia?
This is another consequence. When the stomach is chronically suppressed, the G cells, which produce gastrin, sense the low acidity. They respond by pumping out massive amounts of gastrin in an attempt to stimulate more acid production. It's a sustained compensatory feedback loop.
And what does that do long-term?
Well, chronic high levels of gastrin can cause a proliferation of the ECL cells. And when you stop the drug, it can lead to severe rebound hypersecretion.
So patients stop the PPI, and their stomach responds by overproducing acid like crazy, driving them right back onto the drug.
It's a vicious cycle, and it complicates weaning people off the drug significantly. That's why tapering PPIs has to be done very carefully.
The third major risk involves the stomach's ancient role as a defensive barrier: increased risk of enteric infections.
Gastric acid is the body's first immunological defense. It's a chemical kill switch for most bacteria and pathogens we ingest with our food.
So when you abolish that acid,
You're essentially rolling out the welcome mat. You allow those pathogens to survive and pass into the intestines. This leads to an increased risk of common foodborne illnesses, but the most clinically feared outcome is the increased susceptibility to Clostridium difficile, or C. diff, infection.
C. diff is a serious, sometimes deadly infection that causes severe, persistent diarrhea, and the PPI essentially paves the way for it.
It just lowers the threshold for infection. Studies have shown a very significant association between PPI use and a higher incidence and recurrence rate of C. diff. And this risk assessment is what dictates careful clinical judgment. The benefit of healing a severe ulcer must always outweigh these accumulating long-term risks.
Which means doctors should be limiting chronic PPI use wherever possible.
They absolutely should.
That sets the context beautifully for our next set of tools, because not every problem needs that irreversible lockdown. Sometimes you just need quick relief, or you need to actively rebuild the defenses. We're moving into the support team: antacids, protection, and prostaglandins.
Let's start with the oldest method in the book, gastric acid neutralizers, or antacids. These are the cornerstones of just symptomatic relief. They are basic alkaline substances that react chemically with the stomach acid to raise the pH.
And their defining characteristics are speed and brevity.
Exactly. They act rapidly, often within minutes, but their action is short. We're talking 30 minutes to maybe 3 hours, tops. We measure their strength by their acid neutralizing capacity, or ANC.
Now, we distinguish sharply between antacids that get absorbed into the bloodstream, the systemic antacids, and those that stay confined to the GI tract.
The prime example of a systemic antacid is sodium bicarbonate, baking soda.
Right.
It's highly soluble, acts instantly, neutralizes acid effectively, but it comes with massive trade-offs.
What are those trade-offs?
First, when sodium bicarbonate reacts with hydrochloric acid, it produces huge volumes of carbon dioxide gas.
Which causes belching, distension.
Yes, and it's generally uncomfortable. Second, because it's highly absorbed, it can raise the pH of your entire body, potentially causing systemic alkalosis.
And finally, it's a huge sodium load, right? So it's a no-go for patients with heart failure or high blood pressure.
Absolutely contraindicated.
Yeah.
This is why we shifted so quickly to the non-systemic antacids, which are poorly absorbed and stay mostly in the stomach.
And the two workhorses in this category are magnesium hydroxide and aluminum hydroxide. They're almost never prescribed alone, are they?
No, they're the ultimate power couple because they solve each other's biggest problems. Magnesium hydroxide, which you know as milk of magnesia, is a very effective antacid, but its primary side effect is diarrhea. It's a potent laxative.
And aluminum hydroxide swings the pendulum the complete other way.
It causes severe constipation. On top of that, aluminum can bind phosphate in the gut, which is a big concern for patients with renal failure, where you have a risk of aluminum accumulation and eventual neurotoxicity.
So the magic is in the combination. They're mixed in various ratios, so their opposing effects on the bowel just cancel each other out.
It's a brilliant formulation designed entirely for patient comfort.
We also have calcium carbonate. It's a powerful antacid, but it has its own issues.
It does. Beyond the risk of hypercalcemia, it's notorious for causing acid rebound.
What's that?
The acute neutralization of acid by the calcium ions can paradoxically stimulate gastrin release, which leads to a surge of acid secretion once the antacid's effect wears off.
Driving the patient right back to the bottle. So the ultimate takeaway for antacids is that they treat the symptom, the heartburn, but they don't actually promote healing of ulcers or severe esophagitis.
That's right. And we have to talk about the sheer volume of drug interactions. Antacids are notorious for reducing the absorption of so many other drugs. They do it by changing the pH needed for absorption and by directly forming non-absorbable complexes, a process called chelation.
Right, with drugs like tetracyclines, iron salts, ketoconazole.
All of them.
So if you're listening and taking an antacid for quick relief, what's the practical rule of thumb?
You need to separate the antacid from virtually all other oral medications by at least 2 hours, either before or after, to make sure those other drugs are properly absorbed.
Okay, moving on to our second support category, ulcer protectives. These are drugs that actively create a physical barrier. The main example here is sucralfate.
Sucralfate is basically a pharmacological bandage. It's a basic aluminum salt of sulfated sucrose. But like the PPIs, it has an activation requirement. It needs an acidic pH below 4 to work.
So if a patient is already on a high-dose PPI, sucralfate isn't going to work as well.
It will be significantly less effective, which is a key clinical point.
Right.
Once it's activated by the acid, sucralfate transforms into this viscous, sticky, gel-like substance that has an incredible affinity for damaged, exposed protein.
It literally seeks out the ulcer base.
It preferentially adheres to the ulcer base, forming a physical barrier that shields it from acid, pepsin, and bile.
But it's not just a passive shield.
No, it also has a cytoprotective effect. It stimulates the local synthesis of prostaglandin E and encourages mucus and bicarbonate secretion right at the site of injury. It's a dual-action drug.
What are its main limitations?
It requires diligent dosing, usually 4 times a day, before meals and at bedtime, for 4 to 8 weeks. And its main side effect is constipation. Otherwise, it's very safe since it's minimally absorbed.
We also briefly mentioned colloidal bismuth subcitrate, or CBS.
CBS is another protective compound. It also forms a protective gel over the ulcer at low pH, and it's known to inhibit pepsin. But today, its use is almost exclusively confined to those multi-drug regimens designed to eradicate H. pylori, because it also seems to have a direct antibacterial effect.
That sets us up perfectly for our third support category, prostaglandin analogs, specifically misoprostol.
Misoprostol is a synthetic analog of prostaglandin E1. It's a critical drug because it provides a way to protect the gut from a very common cause of injury and NSAIDs.
So how does it work?
Well, prostaglandins are a key part of the body's natural defense. They maintain mucosal blood flow and stimulate mucus and bicarbonate secretion. NSAIDs cause ulcers because they inhibit the body's natural prostaglandin production. Misoprostol just steps in and directly replaces those missing protective prostaglandins.
So its primary role is cytoprotective, enhancing the defense.
Exactly. It does have a minor anti-secretory action, but its main job is defense enhancement.
So its niche is very specific. If a patient has to take chronic NSAIDs for, say, severe arthritis, misoprostol is the drug you add to protect their stomach lining.
It is the only reliable way to prevent NSAID-induced ulcers, because it directly counteracts the NSAA mechanism.
And we have to issue the firm clinical warning about misoprostol.
Yes, it stimulates uterine contraction and is therefore strictly contraindicated in pregnancy. Outside of that, its most common side effects are diarrhea and abdominal cramps, which can make compliance an issue. But for the NSAID problem, it is indispensable.
Okay, finally, just to complete the historical picture, let's quickly mention the anticholinergics like pirenzepine. They were an early attempt to control acid.
They were really the precursor to the H2 blockers. They tried to reduce the volume of gastric juice by blocking muscarinic receptors, essentially blocking the effect of acetylcholine.
But they had problems.
2 big problems. First, they weren't very effective at maximal acid suppression. And second, they caused pervasive systemic side effects because muscarinic receptors are everywhere: dry mouth, blurred vision, urinary retention. They just couldn't compete with the targeted action of H2 blockers, let alone PPIs.
So we've covered the body's plumbing, the receptors, the irreversible shutdown, and the support team. Now let's move to the most definitive intervention in ulcer disease: eradicating the root cause, the H. pylori regimens.
This is probably the greatest shift in gastroenterology in the last 40 years. We moved from managing a chronic, recurring condition to actually curing a bacterial infection.
Tell us about the bacterium itself. What makes H. pylori so incredibly robust that it can colonize and thrive in the stomach, which is supposed to be a sterile, acidic waste dump?
H. pylori is a gram-negative bacillus, and its entire survival strategy is chemical warfare. It doesn't live in the acid. It lives primarily beneath that thick, protective mucus layer. And its genius lies in an enzyme it produces in massive amounts called urease.
And what does urease do?
Urease breaks down urea, which is naturally present in the stomach, into carbon dioxide and, crucially, ammonia.
Ammonia is a strong base.
A very strong base. This process neutralizes the microenvironment immediately surrounding the bacterium, creating a localized neutral pH bubble where it can live and multiply without being killed by the acid.
So it's basically bringing its own personal acid neutralizer. And why is eradication so vital? Is it just about healing the ulcer?
Eradication is essential not just because it heals the ulcer and prevents it from ever coming back, it's curative, but also because H. pylori is a known carcinogen.
Right.
Eliminating the infection significantly reduces the long-term risk of developing gastric carcinoma and certain types of gastric lymphoma.
So if it's a bacterium, why can't we just give a standard single course of amoxicillin? Why all the complexity?
There are 3 main challenges. First, it's shielded within a mucus layer. Second, it develops resistance to single antibiotics incredibly quickly. And third, and this is crucial, many of our most effective antibiotics, specifically amoxicillin and clarithromycin, only work optimally in a neutral or alkaline environment. They're rapidly degraded or just rendered ineffective by acid.
So the PPI again plays a dual critical role. It's not just treating the ulcer, it's creating the necessary chemical conditions for the antibiotics to actually work.
Precisely. To get the synergy we need, we have to maintain the gastric pH above 6 for at least 18 hours a day.
Hmm.
Only a potent PPI, dosed twice daily, can reliably create that optimal, non-acidic environment that's required to maximize the antibiotic killing power.
Okay, let's detail the standard first-line attack, triple therapy.
Triple therapy is the standard approach, usually given for 1 week, though sometimes up to 2 weeks depending on local resistance patterns. It involves 3 components, all dosed twice a day. A potent PPI, like omeprazole 20 milligrams, and then 2 antibiotics. Amoxicillin at 1.0 G, combined with either clarithromycin at 500 milligrams or metronidazole at 400 milligrams.
And that cocktail gives us a really impressive eradication rate.
It does. When compliance is high, we see rates of 86 to 92%. The choice between clarithromycin and metronidazole often depends on local resistance patterns.
When would a clinician need to escalate to the quadruple therapy?
Quadruple therapy is usually reserved for patients with complicated ulcers, or for those who failed the initial triple therapy, or in regions where antibiotic resistance to clarithromycin is known to be high. It's a more complex regimen that often uses colloidal bismuth substrate in addition to 2 antibiotics, usually tetracycline and metronidazole, and the PPI.
And the bismuth in this case isn't just a physical barrier. It has direct anti-H. pylori action, correct?
Yes. Bismuth has proven bactericidal properties against H. pylori, which makes it a really powerful addition when the traditional antibiotics alone are failing.
Which brings us to the biggest challenge with these regimens, the compliance problem. Despite the high efficacy, it sounds like a miserable week or two for the patient.
It's a critical clinical hurdle. The combination of these strong drugs often leads to side effects in 20 to 40% of patients. We're talking nausea, diarrhea, metallic taste, general GI distress.
And if a patient feels that ill, they're highly likely to stop taking the drugs early.
They are.
And if they stop early, what happens?
The H. pylori survives.
Oh.
And critically, the surviving bacteria have now been exposed to sublethal doses of the antibiotics,
So they quickly develop increased resistance.
often to multiple drugs, which means when the patient comes back, the infection is much harder to treat, requiring an even more aggressive, complex, and expensive rescue regimen.
So patient education and support are just as crucial as the drugs themselves.
It's a perfect example of how behavioral factors can undermine the best pharmacological science. The treatment has to be strong enough to beat the bug, but not so strong that it overwhelms the patient. It's the ultimate clinical balancing act.
Okay, shifting gears now, let's talk about the other major acid disorder. We focused on the erosion in the stomach, but what about the backing up? Let's talk managing reflux specifics of GERD treatment.
GERD is fundamentally different from PR. It's defined by chronic symptoms, heartburn, acid taste, maybe esophagitis, caused by the repeated reflux of gastric contents. And while the aggressive factor is still that acid-pepsin mix, the pathophysiology is primarily a motility disorder.
So not a failure of the lining, but a failure of the valve.
Exactly. The core problem is the transient, inappropriate relaxation of the lower esophageal sphincter, or LES, tone. The LES is that muscular ring at the bottom of the esophagus that should act as a one-way valve. When it relaxes when it shouldn't, contents escape.
What are the common culprits that compromise that valve tone?
Diet plays a huge role. High-fat meals, alcohol, chocolate, nicotine, they all decrease LES tone. Certain medications like calcium channel blockers for blood pressure also weaken the sphincter.
The goal of treatment is twofold: symptom relief, and most importantly, healing the esophageal lesions esophagitis. What's the hierarchy of drug use for GERD?
The hierarchy is strictly determined by the need for sustained acid suppression.
So number one remains the PPIs.
They are the primary drug of choice for all moderate to severe GERD. They provide the necessary continuous acid suppression, keeping the pH above 4 for 18 hours a day, which gives that sensitive esophageal lining time to regenerate and heal. We expect 80 to 90% healing in 4 to 8 weeks. Without that level of continuous abolition, severe esophagitis just rarely heals.
Where do the H2 blockers fit in this hierarchy, given their lower potency?
They're reserved for the mildest cases, stage 1, or for patients who only get occasional symptoms, the on-demand user. Since H2 blockers can usually only keep the pH above 4 for 6 to 8 hours, they're just not sufficient for reliably healing established esophageal damage.
Good for quick relief, but not for serious disease management.
Exactly.
And antacids.
Purely for intermittent symptomatic relief, just for that immediate heartburn. Their 2-hour duration makes them irrelevant for any sustained therapeutic goal like healing.
Finally, we have two specialized GERD treatments that target the physical mechanism rather than the acid. Let's talk about the barrier created by sodium alginate.
Sodium alginate is fascinating stuff. It's a natural polysaccharide that drastically increases the viscosity of your stomach contents. When you swallow it and it reacts with stomach acid, it forms this thick, buoyant, frothy gel layer, a dense raft that floats on top of everything in your stomach.
So when the LES relaxes and reflux happens, the first thing to back up is this inert, thick, protective raft, shielding the esophagus from the harsh acid and pepsin beneath it.
Precisely. It's a purely physical maneuver. It has no effect on acid secretion or LES tone,
Yeah.
but it physically prevents the contact of refluxed acid with the mucosal lining.
And the final category addresses the motility aspect directly, prokinetics.
Right. Drugs like metoclopramide and mosapride aim to fix the mechanical failure. They work by enhancing the tone of the LES, making the valve stronger, and speeding up gastric emptying, so there's less content in the stomach to reflux in the first place.
Since GERD is a motility disorder, adding a prokinetic seems logical. But do they consistently improve outcomes when added to the powerful PPIs?
Well, metoclopramide is specifically indicated for GERD. It's often co-prescribed, but our sources indicate the clinical benefit is often marginal compared to using PPIs alone. The sheer power of acid abolition by a PPI just remains the dominant healing factor.
This has been a complete journey through the evolution of stomach chemistry control. We started with that silent war waged by acid and pepsin.
And we saw the incredible progress. From the flawed genius of simetidine's H2 blockade, which was, just riddled with drug interactions, to the chemical refinement of famotidine.
But the key takeaway nugget that really defines modern treatment is that specific mechanism of the PPI. It's the concept of the inert prodrug, activated only in that extreme acid of the parietal cell, leading to the covalent and irreversible chemical lockdown of the final common pathway.
The H plus K plus AT paste pump. That irreversible binding delivers the transformative power of near-total continuous acid abolition. And that makes it the bedrock for healing severe GERD and, critically, for creating the high pH environment needed to successfully deploy antibiotics and eradicate H. pylori.
This mastery of the molecular architecture has transformed the prognosis for millions. It's cured a chronic disease, and it's preventing cancer. But that success, as we noted, comes with a therapeutic cost. We possess drugs capable of turning off a vital bodily function acid secretion for years at a time.
And we saw the evidence. Compromising calcium absorption, increasing the risk of infection from dangerous pathogens like C. difficile, and altering the stomach's internal feedback loops. The benefit is immediate and profound, but the cost, well, it accumulates slowly and subtly over time.
So, here is the final provocative thought for you to consider. Since we know the risks of chronic PPI use are real, yet prescriptions for minor recurring reflux remain incredibly common, should the initial approach to GER, even mild GER, be a 2-week trial of a PPI followed by a mandatory step-down to a safer H2 blocker or a lifestyle intervention? Or does the immediate powerful relief of the PPI outweigh the responsibility of managing a slow-building potential systemic risk? This is the core ethical and clinical tension in the acid wars today.
Thank you for joining us for this deep dive. We'll see you next time.